Welcome to Observations, an open conversation about women's health. This is a space where physicians, patients, and other experts can sit down and have honest, evidence-based dialogue that cuts through the media bias and brings clarity back to maternal care and how we can care for both patients, mother and preborn child. With each episode, we will have real stories, real science, but also real questions about women's health today. From clinical insights to lived experiences, to aligned perspectives, and yes, also respectful disagreements. This is our goal, to bridge the gap between physician and patient, to empower informed decision-making, and bring back and elevate compassionate, fact-driven care. Now, a quick note before we dive in. Not every guest on the podcast is going to represent the views or positions of Aplog, but we believe that having open and honest conversations are going to make us better. So, grab your coffee, settle in, and let's get into today's observation.
Well, let's talk. So there's lots of different conditions that we could talk about, but I know Jordan in particular is interested in
Selfishly.
That's right, polycystic ovarian syndrome. So I'll start with kind of the doctor question, and then Jordan will follow up with the patient type question. But for those who are listening who might not know what polycystic ovarian syndrome is, or PCOS, can you just kind of briefly tell us what it is and maybe how we traditionally might be taught to treat PCOS, but what you have found to actually be a better approach to treating PCOS?
Absolutely. So PCOS, polycystic ovarian syndrome, is a condition in which the main factor is elevation in testosterone levels. And the elevation in testosterone levels can come from a couple of different scenarios. The most commonly thought of one is when you have very large ovaries with a lot of follicles, especially around the rim of the ovaries. When you have an ultrasound that is done, you see these large ovaries that are about 4 centimeters in size with multiple follicles. The other way that people will be diagnosed with PCOS is if you have more of an adrenal PCOS, where you have very high DHEA levels coming from the adrenal glands, and that is converting over to higher levels of testosterone. And it's really interesting because, we were taught this criteria that you should follow, and you have to have so many of this criteria, and the lab numbers have to be this and that. But what I have found in my clinical practice, and I think I am way more likely to diagnose mild PCOS in people than my colleagues are. And I would base it on, do you have evidence of hirsutism? Because even if you have low DHEA and testosterone levels, it could be that the numbers on the labs are actually being suppressed because of poor adrenal function. But whatever amount of testosterone you have there is still acting in the same way that it would for somebody with PCOS. And so if you have hirsutism on your body, if you have irregular cycles, our workup for irregular cycles off the bat is on day 3 of the cycle, we would check the full thyroid panel. We would check a full PCOS panel, meaning FSH, LH, DHEA, testosterone, 17-hydroxyprogesterone, prolactin, all of this on day 3 fasting. And when we get that information back, then we can kind of see, and most people have kind of a combination of symptoms, as Jordan does. They have some thyroid dysfunction. They also have sometimes even a combination of both adrenal and ovarian PCOS. And so when we look at all of these different labs, the other thing is the timing of the ultrasound is super important. Typical gynecologists were trained, you can get an ultrasound anytime, and the radiologist will interpret it and he'll tell you if it's abnormal, but we completely disagree with that. I only ever order ultrasounds on day 5 to 7 of the cycle. And the reason for that is I want to look at the uterus when the lining is at its thinnest, the ovaries are at their quietest, and I'm most likely to be able to see abnormalities. And I never depend on the radiologist's interpretation because they don't really know that I'm checking this on day 5 to 7 of the cycle. They have no way of knowing whether this is a patient that just has really low estrogen and it's mid-cycle or where we are. So when I look at it, I know that lining should be 5 to 7 millimeters. If it is more than 7 millimeters, I would consider it to be thickened. And if it's thickened, that likely means there's a small polyp there, or this person has very high estrogen levels that they're not able to secrete, and that's building up that lining. I'm also looking for fibroids in the muscle of the uterus, or on the skin of the uterus, or on the inner lining of the uterus. I am looking at the size of the ovary. So I actually want to see the measurements. If I see any measurements that are over 3 centimeters in any dimension, it all automatically will just raise a red flag in my head. And I'm like, okay, slightly larger sized ovaries. Definitely if somebody has 4 centimeter sized ovaries. And it's interesting because sometimes the radiologist may not even read out that a cyst is present, because they'll be like, oh, that's just a follicle. It's no big deal. We don't need to measure that. But you can tell that something's off when the ovarian size is slightly larger. And
Yeah.
when you check back with them, you're like, are there any follicle cysts, anything
Mhm.
here? And they'll be like, oh yeah, there's a follicle. These are the measurements. But on day 5 to 7 of the cycle, we shouldn't see any cysts there, right? Everything should be calm and quiet. So if there are any cysts at that time, I would say there's some sort of ovulatory dysfunction where that cyst is not completely rupturing, it's not completely resolving, and that's an issue. And then the next step, after they've done those initial, day 3 labs or day 4 labs and the ultrasound on day 5 to 7, we move on to having patients check their estrogen and progesterone levels. If it's an infertility patient, they do 12 levels in a row. So they start with the first sign of any sort of stretchy mucus. We have them check estrogen levels every other day, estradiol, until we see a rise and fall in the estrogen. And then we switch. And we know that the highest point in estrogen, we would consider that to be the peak day. 3 days later, we would start checking estrogen and progesterone, and we do it on peak plus 3, 5, 7, 9, and 11. And we're so blessed because there are absolute normal values for this. And so we can compare every value to our normal curve, and then we can see very easily, oh, this person is not creating enough estrogen. If they're infertile, they are likely a person who's going to need some help with letrozole to stimulate a stronger ovulation, or maybe they need help to sustain their eggs better, or maybe they're lacking vitamin D or fish oil or coenzyme Q10. Um, but if they have estrogen dominance all the way through the cycle, we're like, okay, you're obviously pulling back estrogen. Are you drinking coffee? Are you dehydrated? What's going on here? Are you taking some sort of exogenous hormones without even realizing it? Are you adding in certain seeds? Are you, using plastics? What's going on? Do you have chemicals in your shampoos, conditioners, body washes that are xenoestrogens that are converting over? So there's so many aspects to this that just by doing the testing at the correct time,
Yeah.
we have so much to give the patients. And like you said, like we want to increase the number of tools that we have for our patients so that every scenario that comes up, we're not just saying, hey, this is your only option. It's a constant learning, constantly looking to see what is the latest thing. Gut health is huge. Everything begins in the gut. Our mood, the way that we get our vitamins and our minerals, the way that we excrete. So, and most people have really poor gut health. So, trying to really understand what's going on there, and so much to learn.
Yeah.
Yeah, I'm sure like you, Dr. Francis, you probably have a lot of questions about that, I'm sure. But to me, like the first thing I think, I'm just like, oh my gosh, this is crazy. I've just never heard any of this before, because again, I can only speak from that patient side. They checked my ovaries. They're like, oh yeah, they all look great, no problems. And then they actually, this will make more sense to you than it will to me. But they gave me birth control to take down my DHEA levels. And so that was their fix. But like, I still have like the facial hair that comes in on the chin, and all that fun stuff. But yeah, that to me is like very interesting, because in that modern set, like we're given these results and then they're like, oh yeah, everything's fine. And then you actually feel really deflated, or you feel very determined to try to fix your own health, which I think is better than not trying to. But kind of going back to something that you said earlier about creating something for physicians to help them, learn this technology, I think it puts us patients into a better position of not just throwing, spaghetti at the wall and hoping that it sticks, because ultimately sometimes that's what you do as a woman, and you're desperate, you're doing your own research, but to have a physician that can talk about NAPRO technology and run those types of tests, I think is incredibly valuable. One thing I've also noticed is that it feels like PCOS is kind of on the rise. Like, I feel like a lot of people talk about having it, where I'm like, man, where is this coming from? Have you experienced that in your practice at all?
I definitely think it is one of the most common issues that's out there, but it's interesting because I think that irregular cycles are very, very common, and most people don't even realize. Like, most people don't realize they have that's why I made the app, because most people don't realize that they have abnormal bleeding or irregular cycles. They think that it's all normal because that's what their mother had and their sister had or their friends have. And so the app gives them the opportunity to actually see if their cycles are normal or not normal, right? And so when you start looking for anybody who has a cycle length that is not 27 to 29 days, which very few people have a 27 to 29-day cycle. Most people either have, it touches 30 or 32 or 34, or it drops down to 26 or lower. So I believe that true normal cycles are 27 to 29 days. And when you get,
So, so it's not this broad range that we've kind of
no,
been told.
no, because the thing is, I believe that the broad range came from, we've been treating everybody with contraceptives, right? And hiding all of these symptoms. So we have this wider range of what is acceptable and what is normal, because you don't have anything else that you're doing for these women. So what else are you going to tell them? Yes, you've got shortened cycles, but hey, you're using contraceptives. What do you want us to do? But when you really look at it, I believe truly normal cycles are 27 to 29. And when you get under 27 days, those are the people that definitely have more PMS. They have low progesterone because there's not enough progesterone to sustain the cycle,
Sure.
right? And to keep it going until the 28 days. And then when you have women who have 30+ day cycles, that's either PCOS or thyroid dysfunction. And I've seen it over and over and over. And so many
You
people
just
will be like,
described me right there.
yeah. And so many people will
Yeah.
say, hey, I've always had regular cycles, and they may be regular, but they're abnormal in their regularity. So what we were taught irregular cycles meant was people who have like a 26-day cycle, and then they have a 35-day cycle, and then they'll skip a cycle for like 4 months, and then they'll have another bleed, and this time they're hemorrhaging. But when you start to really think about what is happening underneath of all of that, it totally makes sense. If you're not ovulating, then your lining continues to grow. And then when you finally ovulate, you're going to shed all of that lining, which would be much thicker and much heavier bleed. And that leads to crazy heavy, painful periods and all of that. And the same estrogen that stimulates the growth of polyps and the growth of fibroids also stimulates excessive amounts of endometriosis. So the people that have excess estrogen have all of these things typically. God created us so perfectly, and it all makes sense when you actually really understand where it's coming from and you stop trying to suppress everything.
Right.
And then you can try and make a difference, using supplements that help to cleanse your body, or changing your diet, or getting the inflammatory things out to try and lower inflammation in your body so that your body doesn't feel like it's being attacked all the time.
Yeah. Yeah. Man, I'm just thinking too, as you're talking, how many times have I seen patients that, like you said, they have regularly abnormal cycles, right? So maybe they're a 31-day cycle. And so we say, well, then you must be ovulating because you're having a cycle every month. And so, but now you want to get pregnant and you can't get pregnant. And we don't really know why, because we've checked your traditional thyroid hormones, we've checked your TSH and your free T4. And we've checked your traditional thyroid, and that looks normal. And so now
Let me send you on to
have,
IVF.
right, exactly. Now you have unexplained infertility. We don't know why you're not getting pregnant. And so we're just going to send you to IVF because you have unexplained fertility. And IVF, of course, is the only treatment for unexplained infertility. And so we'll send you to IVF. What, I mean, can you address just how common that is? I mean, I don't, just from having seen it in my practice, but how common is that? Because I know that you have patients that come to you after having been told that by other
Yes.
physicians, and
Yeah.
they're seeking a different option.
Absolutely. So, number one, I believe that the term unexplained infertility is a lie. I think that it's not, once again, it's not that the IVF physicians are, just trying to steal everybody's money or anything like that. This is how they've been trained. And when I have never, ever in all of my time of practicing as a NAPR trained physician or a holistic gynecologist or integrative type doctor, have I ever encountered a patient that doesn't have at least 2 or 3 different things happening on the wife's side, and that's not even
Yeah.
looking at the husband, right?
Right.
So when we think about it, when it comes to fertility, the husband is 50% of the fertility. But when they go for evaluation, what do they get? They get a semen analysis, which is interpreted in terms of IVF, right? So when they look at their semen analysis, they're like, oh, you need, just this many sperm because we're going to hand pick your sperm. And so it's okay if the majority of your sperm have 2 heads and 2 tails. That's all right. You've got about 5 of them that don't. So we can just pick those 5. And we need, lower numbers for motility, lower numbers for concentration. They never ever get a full thyroid workup, a check for insulin resistance. They're never told, stay away from heat warmers and make sure you're using a standing desk and, allow your scrotum to move freely. Like, those aren't things that they're advised on. They're never told to get rid of caffeine.
Mhm.
Nobody ever checks a liver function test to see if their liver is struggling at all or if there's higher AST and ALT levels. So, how can you possibly say that you've actually looked into all of the sources of infertility if you're not going to do those things and offer them treatment as well? So, it's a very, very different way of evaluating. And I really wish that more people had an understanding of what they can be offered because IVF costs so much money. Every single month, these people are paying upwards of $3,000 to $9,000, and that sometimes isn't even including the medication. And then they are hyperstimulating their ovaries and they are trying to, create these embryos, and then they are freezing them. And then they're stuck in this never ending, okay, now I have 6 embryos. So I have to keep doing IVF to use all of these embryos. Otherwise, my children are just being frozen there. And the amount of loss of life, they create 10 embryos and they have to throw away 4 of them because they're not good enough quality. And then if they put in 2 embryos and they take off like gangbuster and now they have 4 embryos, next they're being asked to reduce and abort their babies because they'll have an increased incidence of abnormalities with those children and challenges. And so it's a really, really challenging topic and most doctors don't know that they can refer them to, you know, people who are doing NAPRO technology or restorative medicine. And instead they keep sending them to the IVF docs as their only option.
Right,
So
right, absolutely. And like you said, not only does it that pose, some ethical problems, obviously, with the loss of life. We had a talk at our national conference that we just came off of, and they estimate, we don't know for sure how many embryonic human beings' lives have been lost as a result of IVF, but they estimate that only about 7% of embryos that are created actually make it to a live birth. And so when you think about the sheer, and we've had millions of children born after IVF. So when you think about just the sheer numbers on that front, but also, I mean, we all have those patients that from our career that we will never, ever forget. And one of those for me is a woman who very nearly died from ovarian hyperstimulation syndrome as she was going through IVF. It is a very severe sickness that can be lethal for women. And, so there's those health considerations. Plus, there's the ethical concerns with IVF. Plus, there's the fact that all of this, again, I think it's important to point out that the purpose of this is not just to get women pregnant. I mean, that obviously that's wonderful when women can achieve pregnancy because they've, had their PCOS treated or their thyroid treated. But this is also about her long-term health over the course of her life, actually addressing these health concerns that are going on with her. And, that's just something that quote unquote the traditional approach to the infertility workup and our abnormal cycle workup just simply doesn't do, because oftentimes we just are masking it with either the workaround of IVF, if she's trying to achieve pregnancy, or if she says, well, I don't really want to be pregnant right now anyways, great, then we'll just put you on a birth control pill. And while that might temporarily control some of her symptoms, it may give her a quote unquote period every month, even though really all it is a withdrawal bleed. It's not actually a period. She might feel better for a period of time, but of course we're not doing anything to actually fix her. Yeah.
Yeah. I very frequently encounter patients who are kind of on the fence when they come to me. Like, they have an IUD in place, a Mirena IUD, which is secreting a fake progesterone into their body every day. And, I always talk about every single one of these chemicals in hormonal contraceptives, whether it be in the IUDs or in the rings or in the pills or the shots. Those are not equivalent to our natural hormones. They don't bind the same way. They don't leave the receptors the same way. They have many different, issues associated with them, right? And her concern, typically would be, before I got this Mirena IUD, I was having extremely heavy bleeding and really irregular cycles, and nobody was able to do anything for me. And at least now I have cycles that are much lighter, and, my life is not disrupted by them, and I can have intercourse with my husband, and it's not this constant issue. And so when I speak to those patients, I will say, yes, I totally understand where you're coming from. I see how this is the easier route. However, I also just really want you to understand that these chemicals that you're putting in your body are endocrine disruptors, and they're not going to impact your body the same way that natural progesterone would. And you're not supposed to have progesterone throughout the cycle. You're trying to suppress ovulation, and we know that that doesn't happen, in the long term with those IUDs. They continue to ovulate, but it's causing your body to try and fight back, to create excess amounts of estrogen to try and stimulate a stronger ovulation. And all of those things will have resulting side effects from them. And I said, my wish for you is that you'd be willing to remove this IUD so that then we can truly investigate and have an understanding of where your hormones are, and then try and address those root issues. And I understand it's scary because you've been in a really bad place before. But if you're willing to put up with a little bit of discomfort for the meantime as we get, this work done, I don't think it's going to be as bad as it was previously. It may be a little bit irregular, but if we get the stuff done quickly, then we can move on and get to the solution quickly. But it's so hard to check hormones. You can't really evaluate hormones properly if somebody has exogenous fake hormones that they're putting in their body. You don't know, what exactly is happening.
Yeah. So much more complicated than just throwing a birth control pill at it, but so much more worthwhile in the end because of being able to truly help patients, which of course is what we all went into this to do. And and I think what patients are are truly looking for. Jordan, any other thoughts from the patient perspective before we wrap up with Dr. Ruberu today?
The one question I do have, which I think you might be able to answer pretty well, is PCOS curable?
So I think PCOS may not be completely, well, okay, I'll take that back. PCOS that is caused purely from the ovaries with very large ovaries, you can actually do an ovarian wedge resection and reduce the size of the ovaries through NAPR technology type surgery. And I have seen those women go down to pretty normal testosterone levels where they're cycling on their own. So in that sense, I, they still had like 30-day cycles, but at least these are women who were going from not cycling for months and months and months to now
Mhm.
ovulating on a monthly basis and being able to conceive and carry pregnancies. Um, I think PCOS is something that is manageable. Like you can absolutely live your life with PCOS and you can supplement back with progesterone at the correct times and you can, seek solutions to try and help with the hirsutism. And, oftentimes in using the progesterone, you can counterbalance some of the estrogen dominance and maybe improve upon the acne and cleanse your body and do things to try and lower testosterone levels. And so the symptoms can be improved for sure. Um, and then when it comes to, adrenally based PCOS, I think there's a lot of hope as far as doing things to help your adrenals function better, giving back the right minerals and lowering cortisol levels so that you can try and reverse some of that as well. So I think we can do a way better job than what we have been doing.
Yeah, it's been a really eye-opening conversation. Thank you.
Yeah,
Yeah.
absolutely. It's been a joy.
Dr. Barrow, and as we wrap up here, if potential patients are listening, or women are listening who are having issues, but they don't live in Pennsylvania where you're at, I know you have some resources on your website. So how can they educate themselves better, find out more information about maybe some questions they could be asking their doctor, perhaps, as well as how could somebody try to find a doctor who might be trained in NAPRO technology where they're at?
Sure. So I think the most important thing is wherever you are, if you just Google NAPRO technology, any provider that has NAPRO technology type training will put it in their website. And so that's the easiest way, I think, to identify who the doctors are near to you who are using NAPRO technology or have been trained with NAPRO technology. As I mentioned, my app is available for use for anybody all over the world. It's in iOS and in Android, and it's free to use. So if you run into problems with using the app, it is a newer app. And, whenever we encounter glitches, we're always trying to fix it. So let us know if you run into any issues, but that is definitely available. I do have a YouTube channel, Dr. Monique Ruberu, and we have lots of different videos on there as well, speaking about all sorts of different topics. Um, I would, if you cannot find a NAPR technology trained provider, I would next look at an integrative provider. So, looking for somebody who is doing root cause medicine and looking at gut health and helping you to understand if you have heavy metal toxicity or issues going on with your gut, because almost every issue can be improved just by really focusing on your gut health, I believe. Um, that's kind of where I would start. But I do have, shockingly, I have patients who fly to me from all over the world. So it's a joy for me, to see that people are placing such importance on their health and willing to invest in themselves. We also have courses that we've created for fertility if people are looking to, have an understanding of what charting is and how to evaluate their cycles and what sort of labs they should be asking for. I don't have licenses everywhere. I am working on getting licenses in some key places that I have a lot of patients that are reaching out to me. But we're also looking for other providers to add to our office. So, if there's any holistic minded, NPs or PAs who absolutely love God, it may be a good place to kind of move to think about coming to Pennsylvania. So there's a lot going on, and I think there's a lot available for patients. We're blessed to have some really outspoken NAPRO trained doctors out there who are on TikTok and Instagram and all sorts of stuff.
That's right. Absolutely. And tell us again the name of your app.
My app is called NWH Cycle, and our office is Natural Women's Health. So it's naturalwomenshealth.com. And my YouTube is Dr. Monique Ruberu.
Perfect. Well, thank you so much, Dr. Ruberu, for being with us. What a great conversation about women's health. And we could certainly talk for hours more. I think we would have tons of questions, but we'll just have to have you back on the podcast again so we can keep this conversation going. But thank you so much for the work that you're doing to empower women with good information about their health. And thank you also for being an AppLog member.
Thank you. It's always a joy to be with you guys and happy to be a part of AppLog.
Absolutely. Thanks so much. And thank you to our listeners and viewers for joining us this week. We'll see you back here next week. Well, welcome back to another highlight of one of our sponsors from our recent national conference. And I'm so excited to have with me today Mary Zock, the director for the Center for Human Dignity at Family Research Council. She's a dear friend and a wonderful champion for life in the work that she does at Family Research Council. And we were so thankful to have FRC as a silver sponsor, like I said, at our national conference this year. And we just really wanted to spend a little bit of time highlighting the important work that FRC does. So, Mary, thanks so much for joining us.
Oh, thank you so much for having me. And thank you for all the work that AppLog does defending the unborn. You guys bring such wisdom, and just your brilliance just shines through, and it makes it really hard for pro-abortionists to argue with our side.
Well, thanks so much, Mary. We are likewise so thankful for the important work that FRC does. And I was thinking, and the collaboration with FRC and AppLog may go back to even before this, but the long time collaboration that really sticks in my mind is one of your colleagues, Chris Gasick, I know has worked with Donna Harrison, our CEO Emerita, since even before mifepristone was approved in the US. They started working together to really highlight the dangers of the abortion pill mifepristone. And so that was back in the late 90s. So this collaboration has really gone on for quite some time. But for those that are listening or watching that may not be aware of the important work that Family Research Council does, can you tell us about sort of the general work of FRC, but then also specifically about the work of the center that you lead?
Sure. And first, Chris Gasick and Donna Harrison, two of the giants that the pro-life movement is standing on their shoulders. So grateful for the work that they've done, and so grateful to have Chris at FRC, where he really can tell the history of everything that's happened in the pro-life movement and tell us what's been tried before and what hasn't been tried yet. At FRC, we try to bring a biblical worldview to the national political scene. And we engage with politicians on Capitol Hill, and then we engage with folks who are in the pews, and with Christians who are seeking to live out the teachings of the Bible in their daily life, seeking to apply those teachings that we find in Scripture to what's happening in our political world. So really just trying to bring the message of the good news of Jesus Christ to our modern culture and to our political realm.
Amazing. And then you lead the Center for Human Dignity. Tell us a little bit more about what the work that your center does at FRC.
I do, and it's such an honor to be there and to be able to work to champion those who are weak and vulnerable among us. So we do what people immediately think of. We work on the issue of abortion and protecting unborn children in the womb. We do that on a national scale. We work with state legislators on that. And we create educational materials so that we can have those difficult conversations with our friends and family members to really work to change hearts and minds and bring people in alignment with Christ's view of the unborn child. But we know that the dignity of the human person extends throughout life. And so we work on the issue of adoption. We work on the issue of IVF and the dangers that are surrounding a completely unregulated IVF system. We work on issues that people with disabilities face, like assisted suicide, that is becoming a rampant issue in Canada, especially, but it's taking hold here in the United States as well. So it's really an honor to be able to be there and to fight as much as we can for those whose voice needs to be amplified.
Absolutely. Well, and you bring up Canada on the assisted suicide issue. It really is uh, becoming just a really horrific place when it comes to suggesting, I would say coercing people with physical disabilities, mental disabilities, or even, a recent case of a young man with just really severe depression that was really urged towards that. And we had a representative from Canadian Physicians for Life, a couple of them actually, at the conference recently. Their fellow Alliance for Hippocratic Medicine members, and yeah, just talking to them and hearing where they have seen their country go. It's so important that we have groups like FRC in the US working to really resist the coming tide that has been building, I think, in the US on that issue. Before we get to some new initiatives maybe that you all are working on, you brought up one thing. And of course, APLOG is not explicitly a religious organization, but I myself am a Christian, and we have many, many members who are people of faith. And you brought up the fact that FRC really is seeking to bridge um, what I think a gap that maybe exists between what's happening in the political realm and the church and people of faith. I wonder if you could just speak to that of your perspective, because I've heard many people say, we should be keeping politics out of churches, that sort of thing, and that those two things shouldn't mix. And while I understand maybe a little bit of where they're coming from, it's so important that church leaders, that people that are attending churches be involved in having their voices be heard in the political process, I think. And so I just would be interested to hear your perspective on that.
Sure. So, scripture tells us go out and make disciples of all nations. We're not meant to live in an isolated society where it's a little utopia where everyone is already Christian. We are called to be the light that shines in the darkness, and we're called to bring that to every aspect of our life. We are meant to spread Christ to the world and to not be impacted by what the world says. And it's awfully hard, especially for those involved in politics. There's certainly a number of good Christians in Congress. But so often when we look at the political sphere, love your neighbor, it's just not there. The recognition of the unborn child as the being that God himself knit in their mother's womb, that is certainly not there especially for Democrats. And this is something that we need to make sure is there in our homes, because that's where this starts. Those members of Congress, they didn't just become members of Congress out of nowhere. They grew up somewhere. They were influenced by their peers and their friends. And that's where, as Christians, if we can influence those in our homes, if we can have the difficult conversations with our sons and daughters and brothers and sisters and parents and our neighbors, that makes it so much easier when we get to the congressional level, because those conversations spread, and the light of Christ always spreads. It always overcomes the darkness. But right now, at least when it comes to the dignity of human life, there's a lot of darkness. And so we need to really be that light that's shining.
Yeah, absolutely. So important. So important that regardless of political party, although, we certainly know that some political parties lean much more towards supporting life than others. But regardless of political party, we need people to be in politics that are going to be advocating for the most vulnerable amongst us, for the preborn children, for women that are harmed by abortion as well. And so it's really important that people of faith who have those convictions be involved in that process. And I will also say that FRC puts out, Mary, you said that you guys provide resources, which you absolutely do, for having those difficult conversations in our spheres of influence. And I do have to commend FRC puts out some amazing white papers on lots of different topics that give you really good talking points for being able to defend the pro life position. One of my favorites is the top 10 myths about abortion document that was written in conjunction with our dear friend and APLOG board member, Dr. Ingrid Scott. So that's just one of many amazing resources that are available. But Mary, any other resources that you want to highlight or new initiatives that FRC is working on right now?
Well, right now and I'm sure similar to APLOG, we are laser focused on trying to tackle the issue of abortion by drug. And we see this as a special tool of the devil, because abortion by drug makes abortion an impulsive decision. It makes it one where a woman either just pops a pill, or her abusive or coercive partner pops that pill into her drink or sprinkles it on her pancakes, puts it in her hot chocolate, and forces her to take it against her will. And this is not of God. No abortion is of God. But this is a way that the devil is especially using our times, when so many decisions that we make today are impulsive ones. And this is another time that the abortion industry is trying to prey upon women using that impulsivity. They are long gone when the woman is alone in her bathroom, devastated, as she's delivered her visibly recognizable unborn child into the toilet. There's no one answering those calls from the abortion industry. And so we are working especially hard to fight that. We know that those drugs almost always kill an unborn child. There is the chance of reversing the abortion pill regimen, as you know, if caught in time. But they almost always take the life of an unborn child, and very frequently they leave the mother's body broken. And they leave her to figure out whether she's experiencing symptoms of an abortion or if she's experiencing life-threatening symptoms. So that is our focus. We have just published a timeline of mifepristone, of the impact of mifepristone, and some of the impact of misoprostol, where people can see they can see the government action on mifepristone coupled with the devastation that it has brought to women. And I think that this resource is something that will be helpful to folks who just really want something comprehensive on what has happened with mifepristone. We also recently published our mifepristone, The Deadly History. And this resource really shows how abortion by drug was the abortion industry's backup plan to us in the pro-life movement overturning Roe. Everyone in the pro-abortion movement knew that Roe was wrongfully decided, that they loved the decision, but if they were intellectually honest, they knew that it was a really poor decision based in nothing. But mifepristone was their backup plan to that. And now it's being mailed into pro-life states across the country, devastating women, allowing abusers to use it as a murder weapon against women and their unborn children. So that's our top focus right now. And I'm sure that's something that APLOG is focused on too. And I know we're partnering together on some of that.
Yeah, absolutely. Well, that's very exciting to hear about those new resources, because I think it's so important for people to be educated, and again highlights what a great partnership it is between APLOG and FRC. You all can provide that historical perspective, the sort of political perspective as well of where we've come, and APLOG can provide that medical perspective of exactly why these drugs are so dangerous to our patients. So we'll make sure that we link both of those resources in the show notes so that people can access that, because if you haven't looked into really the sordid history of where these drugs came from, why they were pushed on the American people, I think it will be very eye-opening, very enlightening, and hopefully spur you towards joining us in this fight against against mifepristone, which, the way it's being dispensed now negates every single pro-life state law across the country. It means that women and unborn children across the country in all 50 states are being actively harmed by these drugs each and every day. And so I know it's very important to both of our organizations. I believe you all as well. Is your petition still ongoing that people can get on and sign if maybe they're a little hesitant to reach out to their members of Congress on their own over this issue? They can do that through you all, I believe. Is that right?
That's correct. Yes, that's available at frc.org.
Amazing. Amazing. Well, Mary, just as we close up here, can you just let us know why FRC felt like it was so important to partner with AppLog to be a sponsor at our recent conference? Without our sponsors, we could not put on the amazing conferences that we do that are so encouraging to so many who come. But tell us why it was important for FRC to partner with AppLog in our conference this year.
AppLog is the tip of the spear when it comes to defending life. The physicians there bring an authority from their extensive medical background that the rest of us don't have, and they're able to speak knowledgeably about the development of an unborn child, about what happens to that unborn child in the womb. And they do so with such care and diligence and so much compassion and love for mothers and for unborn children. We're so grateful for the work that AppLog doctors do. They're frequently putting their careers on the line to stand up for the unborn. And in this day and age, I don't think it's an exaggeration to say that often they're putting their life on the line too. And we know that God sees that. And we're just so grateful for the work that you all are doing.
Thanks so much, Mary. I echo your sentiments for all of our amazing members. And again, it's so important that we put this conference on every year so that they can come and not only be encouraged by learning more and more information that will help them in their practices, but also just be encouraged by networking with other like-minded professionals, but also being able to interact with amazing organizations like FRC. So thank you again. Please convey our thanks to everyone there at FRC. And Mary, we look forward to just continued partnerships as we defend women and children from the harms of abortion.
We hope that you enjoyed today's episode of Observations and that it broadened your perspective on women's health and how we can care for both patients, mother and preborn child. If you like this episode, make sure to give us a 5-star review where you can find your podcasts. Make sure that you like this on YouTube and subscribe to our channel for more episodes coming up. And if you have any suggestions on any topics that we should cover or guests that we should have on, make sure that you email us at media@applog.org. Again, thank you for joining us for today's observation, and we'll see you in our next episode.